So other things that patients may describe, but not necessarily, like if you're watching them, you're not going to be able to pick it out, are things like they may start to say they have pins and needles up one side of their body. They might have some numbness. Obviously, the things on the bottom, I think if you guys were in the room when a patient started doing any of these things, you would think of pushing the button or having the nurses come in. So if they're having uncontrollable belching, incontinence you're not going to necessarily know about, but if they start looking flushed, sweating, or vomiting, of course, you're going to push the button and you're going to get help for them right away. And then patients can also, we showed that one woman who had the visual hallucinations where she was describing what was going on. If they suddenly say they have an unpleasant smell or a taste, they might be able to describe it, but if they haven't pushed their button, go ahead and encourage them to. We already saw this lady. This gentleman, since we flip back to the slideshow, so he is just sitting there in his bed and suddenly just starts uncontrollably crying. Not for any reason, no one has hurt his feelings, he's not hurt. He just, sometimes patients become very emotional during their seizure, and it's not because of a particularly inciting factor, and suddenly they just start crying. So if you saw something like that, you'd want to go ahead and push the button. So what happens when you do push the button is if the patient is having a tonic-clonic seizure, so that's what we call a grand mal seizure where they have a full body convulsion, body stiffening, the nurses will come in. You guys, all you're expected to do is to make sure that somebody's coming in that room. If you've pushed the nursing call bell and there's not somebody going into that room and you see them going into one of the bigger seizures, yes, absolutely, go into the control room. You can call down the hall, but make sure that someone is physically going into the room. What they will do is they will put oxygen on the patient's nose. That as soon as the convulsion ends, they will roll them on their side while they are recovering, and they will just try to keep the patient safe. If the patient is having a complex partial seizure, meaning they have altered awareness, but they haven't gone into a full convulsion, they'll start asking them questions. They'll start asking them to interact and to see if they're able to respond and how responsive they are. These aren't things we would expect you guys to do, but just so that if you're in the room and you see them, this is what they're doing, this is why they're doing it, is so that when we come back and see the patient later, we figure out whether they remember what happened or not, so that we really know what type of seizure they're having. Sometimes seizures can look very bizarre. So in this video, the woman just hunches down like this. Sometimes people can have these wild bicycling movements. They kick their arms and legs. If you saw it and they were doing it out on the street, you would not think it's a seizure because it's so bizarre. So if suddenly they're doing things like that, those can be what are frontal lobe seizures, where patients just have what we call hypermotor activity and can do any sort of bizarre behavior. So if it's something out of the ordinary that during your testing that they're doing, just go ahead again and push the button for that too. We saw this gentleman, and then we already talked about with the tonic-clonic seizures, typically it's not exactly like what you see on TV. What patients will do is they'll have that body stiffening that I showed you with the little boy, and then they'll start having kind of rhythmic jerking of the body, and then sometimes they sort of stiffen again. At the beginning of those seizures, they usually have something called an ictal cry, and if you've seen them before, it can be a little bit scary because all of a sudden they just yell out like that. What that is the diaphragm is contracting and pushing all of the air out, and so all of a sudden they'll make this very loud noise. And that, if you hear that loud noise, it sounds like that button right away, because that means that patient is going into a tonic-clonic seizure or convulsion. And then we go through all these steps in terms of treating the patient, because they do become obtunded, they don't breathe right away during the seizure, and so we provide oxygen to them during the recovery period. And so we do the video EEG monitoring. The reason we have these patients in the epilepsy monitoring unit is so that we can get the ictal recordings to figure out where the seizures are coming from for the purpose of epilepsy surgery. We do explain to patients that we're taking away their medicines. They may have stronger seizures than they would have otherwise. Status epilepticus is where they go into a seizure that we can't stop. And so we know that in some instances that can happen when they're in the epilepsy monitoring unit. And if that were to happen, the patient goes back to the neurocritical care unit until they're stabilized. And then we decide if they're safe to continue with the monitoring or not. And so that's the other reason that we try to be prepared to act react immediately with seizures is because if seizures go on longer than a minute, sometimes they don't stop on their own, especially if they've gone on for 5 minutes. They really don't tend to stop on their own, and patients are at risk for status epilepticus. So about 10 to 15% of patients that I see in my clinic, or that we see in general, fail anti-epileptic drug therapy and are candidates for the surgical intervention. Usually they've been tried on at least 2 medicines and have continued to have seizures that are disrupting their life, and that's why we have them here. You guys have seen a lot of the components of the workup. The part that you're seeing here is the epilepsy monitoring unit, but they've often undergone lots of other testing procedures in preparation for it. And so the reason we do the invasive EEG for these patients is that some of these procedures may not have been concordant, meaning we found on the regular routine EEG or the scalp EEG that their seizures came from the left, but the MRI shows a lesion on the right. We know that the seizures are coming from the left, from the dominant cortex, and we're worried that it might be near language area, so we're trying to figure out that before we plan for the surgery, and we just need more information. So those are examples of why we do the invasive monitoring. You guys have seen, this is what depth electrodes look like. So these are electrodes that are sampling the cortex, that are sampling the mesial temporal structures, the amygdala and hippocampus. And then these are strip electrodes that we place subdurally to record from the cortex itself. This is the before lunch picture of what it looks like in the operating room when these electrodes are being placed on the patient's brain. So in this case we have an 8x8 grid, and then we have other electrodes that are wrapping around the brain, and you can see what that reconstruction, obviously this is an older one, the ones we do now are much better, but what a reconstruction could look like after you've put those electrodes on. And then what happens is those tails of those electrodes go through the dura. The patient gets, the skull is put back on, everything is closed up, they get a big wrap around their head. They go from the operating room to the neurocritical care unit overnight. They're observed, and if they're safe, they come to the epilepsy monitoring unit. Now what's tricky about that is that maximal brain swelling after these procedures happens in 48 to 72 hours. So they went to the NCCU, they come to us after 24 hours. Friday, you may see a patient, you may walk, like if they had their surgery on Thursday, they may look pretty good. But then you show up Saturday morning to do your testing, ready to go, and this patient is in extreme pain. All of a sudden their eye is swollen shut, so you'll see this, like their whole side of their face is swollen, and that's because they're reaching that maximum edema. So the edema is on the outside and the inside, 48 to 72 hours. And that's another reason why if you see a patient that starts vomiting at 48 to 72 hours, Saturday, Sunday, you're going to let somebody know right away, because that could actually mean that the swelling has been too much, and those patients can herniate, meaning that their whole brain can actually go